I want to come back around to something we were talking about early in the conversation. And we got into the disruption of the glycocalyx, endothelial dysfunction that impacts nitric oxide. But let's talk about plaque. We talked about the two different ways it can gradually increase and cause an occlusion of a vessel or more drastically. But let's talk about specifically the more sudden, the rupture. What specifically causes that? And then what's the physiology that happens afterwards?
There are variable causes, but high shear stress, you know, oxidative stress and inflammation that thins out the cap of the plaque, probably the most common reasons. So think a plaque in the artery is a pimple. If it has a very thick cap over it, it's not likely to rupture. If the artery lumen starts getting occluded to where it's 70% occluded, you may have stable angina. You'll have chest pain when you exert yourself and get your heart rate up, but that plaque is not likely to rupture. Unfortunately, when I said earlier, still true, is half the time people have heart attacks, the arteries might look something like this. They got 30% blockage in the artery. They can't feel that. But that plaque, if it is thin capped, think of it as like a red hot pimple. The cap ruptures, the damaged, modified, oxidized LDL, the macrophages, the other immune components that are in that plaque, they then spill out into the bloodstream. The body then senses that event is a bleeding event. The body, someone thinks like the body's bleeding externally, and then platelets get activated. The platelets form a plug. It seals that rupture, but it also acts like a dam. It prevents the blood flow going downstream. So whatever tissue downstream is being starved of its oxygen and nutrients. So if it's in the heart, that's a heart attack. If it's in the brain, it's a stroke. If it's in your gut, it's going to be a mesenteric, infarct, and you're having belly or gut pain, or a kidney infarct. So the rupturing process is generally sudden. The person did not have symptoms before that happened.
How do you feel about the clotting aspect and the quality of the blood and things we can do to impact that and make sure it's got proper viscosity and such?
Well, we talked about those things earlier. It's grounding to improve the zeta potential. It's doing things that structure the water in your bodies. So sun exposure, exercise would help with that. Sauna could help with that. So it's mostly the lack of infrared light and the lack of grounding, getting electrons through that way to do it is one of the things that causes the blood to be more um, viscous, more like ketchup, less like red wine.
Okay. What about specific things like people talk about fish oils to keep the blood thin, other dietary changes, supplements?
I mean, it's more of a myth that fish oil is a blood thinner. I mean, it may help with some of the platelet aggregation, but it's not like aspirin, clopidogrel, or like, anticoagulants like warfarin or, Xarelto. It's not like those things. So, I mean, people can, I think there's older studies where people were Inuit were eating like 20 grams a day of omega-3 and they had no increased risk of bleeding. So I don't really consider omega-3s as a blood thinner. Um, but, there's people that, will talk about nattokinase, serrapeptase, lumbrokinase. If you have high fibrinogen levels, maybe it makes sense, but I don't think the average person needs to really, really be focusing on that.
Genetics have come up a few times. I want to end on this. FH, you quickly brought it up. How often are people coming to see you with this genetic component? And how different is the diet and lifestyle with that person?
So how often do people come see me? Well, I have a kind of a unique, practice. So more common to see them than probably a general cardiology practice would, because people know my expertise for looking at lipoproteins and helping with vascular diseases. So I just before this interview saw somebody who traveled from halfway across the country to come to see me who has confirmed familial hyperlipidemia, has an issue with their LDL receptor. So the LDL receptor sits on the outside of the liver and plucks the cholesterol particles out of the circulation. This person doesn't make very many of those, so their LDL particles were extremely high. And because they already have somewhat advanced vascular disease for age, they're on very aggressive pharmaceuticals and are doing very well at this point. But the differentiator is that this person had high lipids since they're first are checking in their 20s. So the person who's following more of a keto type diet and is now quote a lean mass hyperresponder, they have to have had some type of panel in the past that was quote normal, and then you see a significant elevation in their LDLs, typically above 190 milligrams per deciliter. It mimics familial hyperlipidemia, and they may still get atherosclerosis with that. Just because they're metabolically healthy doesn't mean that their arteries are immune from developing plaque from that number. So that's why you have to test and not guess on it. But if you do the right type of genetic testing, you can rule out that it's not due to familial hyperlipidemia. But oftentimes it's due to polygenic reasons. So the GB Health Insight Panel can tell you, say perfectly ate, you exercise every day. If you have a, polygenic risk score for hypercholesterolemia of 98 out of 100, you're going to have high levels no matter what you do. Then it's your choice to decide if you want to take, therapies to adjust your lipoproteins at that point. But if you have plaque in your arteries, you probably should be considering that.
If you enjoyed that clip, you're going to want to head over here and catch the full episode. I'll see you over there.
Atherosclerosis is a lifelong disease. It can start in utero, can start before you're born, but you typically don't present to a doctor with symptoms until you're in your 40s, 50s, or 60s. And people can live their entire life, have these plaques, and not know that they're there.